السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الخامسة, we will continue our lecture in rheumatology. The new subject is systemic sclerosis. What is systemic sclerosis? As the name of the disease apply, it is more than one system. It is systemic, involving more than one system, and it is sclerosis, mean fibrosis. So it is a fibrosis that involves more than one system. So it is an autoimmune disease characterized by fibrosis, which results in thickening and hardening of the skin, which is the main system to be involved. That is why sometimes we call it scleroderma, because skin fibrosis and hardening. But internal organ can also be involved, and it's common, and it is one of the main causes of morbidity and mortality is internal organ involvement. The disease peaks in the middle age and is more common in female, with female to male ratio is 4:1, and overall prevalence is 10 to 20 per 100,000. Generally speaking, the disease divided into two main subtypes, which is diffuse cutaneous systemic sclerosis and limited cutaneous systemic sclerosis. The division of these two subcategories depend on the skin involvement, whether it is diffuse skin involvement or whether it is limited. What we mean by diffuse? Diffuse skin involvement means the skin fibrosis and hardening involving the extremities, meaning the arm, the hands, forearm, and proximal to elbow, where arm involved, and the trunk, in addition to the face and neck. While a limited cutaneous systemic sclerosis, the hand and forearm also involved, but does not progress proximal to the elbow. So the arms is preserved in limited time. Also, the trunk and the abdomen is preserved, while head and neck is involved in both subtypes. So to differentiate between diffuse from limited type, we see, is the lesion proximal to the elbow and knees or not? If it is involving proximal to the elbow and knee, it is diffuse type, otherwise it's limited. Diffuse type constitute about 1/3 of cases, while limited type is the other 2/3 of cases. How the disease occur? What is the pathophysiology? Although the disease is autoimmune and not completely understood, there is a clear evidence of autoimmune or immunological dysfunction, where T lymphocytes play the major role in the initiation of inflammation that lead to fibrosis. Mainly a subtype of T helper cell, Th17, which infiltrate the skin, and with production of cytokine, there is abnormal fibroblast activation, leading to the increased production of extracellular matrix in the dermis, primarily type 1 collagen, which lead to the fibrosis of the skin and the hardening and induration we talk about later. This will result in symmetrical thickening, tightening, and induration, meaning fibrosis of the skin or scleroderma. But not only the dermis and the skin will be involved, there is also involvement of the small vessel in the skin. Any arteries and arterioles will be narrowed due to intimal proliferation in the vessel wall, inflammation with endothelial injury cause the release of vasoconstriction, and further aggravating ischemia and further activation of fibroblast cell. So the disease will continue, never progress. How patient with systemic sclerosis present? We said it is systemic, so let's talk about it by one system each time. First and most common system to be involved is cutaneous manifestation, or cutaneous or skin system. So what is the cutaneous manifestation of patient with systemic sclerosis? As we said, the disease pathophysiology started with inflammation within the dermis inflammation lead to swelling. So the disease initially, before the induration, starts with edema within the skin, which is non-pitting due to the inflammation, which starts in the small fingers and progress proximally to involving other parts of the body. After the edema, where the inflammation subsides slightly due to the development of fibrosis, the skin will become shiny and taut due to stretching of the skin, and distal side of the skin creases will be disappear again due to stretching. With the inflammation, there could be pruritus, and when we see a patient with systemic sclerosis, his face will be characteristic. As we see, there is thinning of the lips margin, radial furrowing around the mouth opening, with beak nose, like a beak of bird. When we get closer look to the face, we see a lot of telangiectasia, which is dilatation of small vessel. The hand of a patient with systemic sclerosis, we see there is loss of skin creases. The skin is shiny, and there is some area of ulceration due to involvement of small vessels supplying the skin. Rhinoid phenomena is a universal feature and can precede the systemic manifestation by years. In severe cases, where the ischemia and rhinoid phenomena is severe, there will be necrosis and autolysis even of the bone of the finger. This is another patient. You see, because of fibrosis, there is stricture formation and the patient unable to extend his finger fully. There is a picture look like a clubbing, but it is actually not a clubbing. It's due to autolysis of the distal fingers and nail curving. It is not true clubbing, and the patient is unable to extend his finger fully. This is maximum degree of extension this patient can do. This we call it Brayer sign. The patient unable to extend his finger when he put his hand opposite to each other. This is Brayer sign. Next most common system to be involved is the musculoskeletal system, where patient usually complaining of arthralgia, mainly myalgia, fatigue, non-specific symptom. But true arthritis, where swelling and hotness is not a typical feature of systemic sclerosis. Likewise, joint erosion should suggest an alternative diagnosis, and if we sure this patient has systemic sclerosis and his joint develop arthritis and joint erosion, we should think this patient may have over-added rheumatoid arthritis in addition to his systemic sclerosis, a condition we call it overlap syndrome. Due to the stricture formation caused by tendon fibrosis and skin fibrosis, restricted hand function will occur, and when fibrosis occur in tissue surrounding a nerve, a neuropathy will develop. GIT system involvement is common, occur in more than 70% of patients, where it could involve pharyngeal muscle, resulting in dysphagia, or could result in esophageal hypomotility, and when lower esophageal sphincter involved, it will lose its function and result in reflux, chronic gastroesophageal reflux. Sometimes, due to weakness and dysmotility in the bowel, a lot of diverticulum could develop, especially in the colon, and these diverticula may become a site for infection. That is why small bowel bacterial overgrowth is common in patients with systemic sclerosis. Lung involvement is common, and there is two types of lung involvement in patients with systemic sclerosis. It is either interstitial lung disease, where lung fibrosis, like any other system, it will be involved by fibrosis. It is usually more common in patients with diffuse type of systemic sclerosis, while the other type of lung involvement could be pulmonary hypertension due to involvement of pulmonary vessel alone without lung tissue involvement, which occur with long-standing disease, and it's 6 times more common in limited type than in diffuse. So pulmonary hypertension more common in limited type, while lung fibrosis and interstitial lung disease is more common with diffuse type. Renal involvement is very important, as it may be the leading cause of death in patients with systemic sclerosis. Kidney involvement is more common and more severe in diffuse type of systemic sclerosis. The most striking and life-threatening manifestation, we call it scleroderma renal crisis. It is a specific entity. We call it scleroderma renal crisis, which occur in 10 to 15% of patients, usually in patients with diffuse type, and tend to occur early in the course of disease. When it occurs without treatment, the mortality rate is nearly 90%. Typically, these patients with scleroderma renal crisis presented with elevated urea and creatinine, decreased urine output, a new or worsening of hypertension, proteinuria, and characteristically microangiopathic hemolytic anemia, meaning there will be decrease in HP and platelet count. Some patients will develop, due to severe hypertension of course, pulmonary edema and sometimes even hypertensive encephalopathy. Although patients with scleroderma renal crisis have acute kidney injury with elevated urea and creatinine, and you all know that AC inhibitor and ARB have caution, should be used with caution in patients with renal impairment, the treatment of choice in patients with scleroderma renal crisis is ACE inhibitor as a vasodilator. Will significantly improve kidney survival and decrease mortality among patients with renal crisis, because it will increase blood supply to the kidney by vasodilation effect. So treatment of choice is ACE inhibitor, and more specifically captopril. Now, before we go to investigation, we have few terms we need to know something about it. First, many patients with limited type of disease have a manifestation, we call it a CREST syndrome. What is a CREST syndrome? It is a collection of many symptoms. C for calcinosis, R for rhinoid phenomena, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. When we gather it all together, we get CREST syndrome, which is a subtype of limited disease. What about scleroderma? Scleroderma means tightening and fibrosis of the skin only, without the involvement of the internal organs. So when we say systemic sclerosis, we mean involvement of the skin and internal organ. But if we say only scleroderma, we meaning only the skin involvement without internal organ. So scleroderma is part of the spectrum of systemic sclerosis. Another term, systemic sclerosis sign scleroderma, meaning sclerosis and fibrosis of the internal organ without skin involvement. This is the reverse of scleroderma. Here, no internal organ involvement in systemic sclerosis sign scleroderma. Only internal organ occur without skin involvement. What about investigation? Because systemic sclerosis affects more than one organ, so a lot of routine investigation need to be done to assess the function of this organ, like hematological investigation, renal and liver function tests, bone function tests, and urine analysis looking for protein, urea, and active renal sediment. Anti-nuclear antibody is positive in about 70% of patients. It is highly sensitive for systemic sclerosis, but is not specific. As all of you know previously, it occurs in other diseases, mainly SLE. So it is sensitive for systemic sclerosis, but not specific because it occurs in many diseases. What is specific is another antibody. We call it topoisomerase 1 or SCL70, which occur in 30% of patients with diffuse type. This is specific for diffuse systemic sclerosis, but you see it is very low sensitive. So negative test does not exclude the disease. Other antibody which is specific for limited type is anti-stromer antibody, which is sensitive for 60%, better sensitivity than topoisomerase, but highly specific for limited type. More advanced investigation in form of imaging, chest X-ray, transthoracic echo, and lung function tests are recommended and usually done on a frequent interval to anticipate the development of interstitial lung disease and pulmonary hypertension. And final, patient with shortness of breath, high-resolution CT scan is recommended to establish the diagnosis of interstitial lung disease. What about the management? First thing you need to know, there is no cure for this disease, and also there is no treatment that can stop the progression of disease. So a lot of management directed toward treat the morbidity associated with that disease. So for rhinoid phenomena, which majority of patients complain of pain and coldness in their fingers or digital ulcer, main line of treatment is to avoid cold exposure. Try to keep your fingers and hand warm by glove and stocks, and maintain high core body temperature. While pharmacotherapy, we can use a lot of vasodilator like calcium channel blocker, losartan, sildenafil. Many have effect. For GIT complication, accordingly, if patient complaining of GERD, so treatment of choice will be proton pump inhibitor and advice regarding dietary modification. For patients who have dysmotility and bowel movement with prokinetic drugs can improve dysmotility. A lot of drugs like metoclopramide, domperidone. In patients with small bowel bacterial overgrowth, we can use rotatory course of antibiotic like rifaximin, tetracycline, or metronidazole. For patients with hypertension, need aggressively treat, as hypertension is one of the main determinants of scleroderma renal crisis. And the treatment of choice will be AC inhibitor, specifically captopril, even if renal impairment is present. For pulmonary hypertension, we need early treatment, as early as possible, with endothelial receptor antagonist, bosentan. If interstitial lung disease develops, then we need to treat the patient with immune suppressive drugs, more specifically steroids, and cyclophosphamide are the mainstay of treatment in patients with interstitial lung disease. Thank you very much.